Good morning and welcome to Riverside Talk. Today's topic, Memory Matters, Insights into Alzheimer's and Dementia Care. My name is Denise Mananis. I'm the Associate Vice President for External Affairs for St. John's Riverside Hospital. And before we begin and before I introduce our wonderful speaker today, I would like to just thank my team, Jason Latore, Nancy Anabi, and Candace Cousins-Hopkins, without whom we could not produce these programs for our community. So before we get into the nitty-gritty about Alzheimer's and dementia, I would like very much to acknowledge our community partners. Yonkers Neighborhood Naturally Occurring Retirement Community and the Yonkers Public Library are our original partners. And our new partners, the Ashling Irish Community and Cultural Center, Department of Veterans Services, City of Yonkers, Ardsley Parks and Recreation, Ardsley Senior Center, Bronxville Community Center, the City of Yonkers, Community Baptist Church, Hastings Community Center, Irvington Community Center, Westchester Jewish Community Services, and Yonkers Pathways to Success. So thank you to all of those groups that help us get our webinars out into our community. So today, this has been a topic that we've wanted to cover quite a bit, and we got the best doctor to do that for us. So let me introduce you to Dr. David Dickoff. He is a neurologist who has been caring for patients in Westchester for over 37 years. Dr. Dickoff graduated from Albany Medical School with Alpha Omega Alpha honors in 1982 and completed an internship in internal medicine, followed by a neurology residency at Mount Sinai Hospital. He was the first to describe delayed carbamate pesticide toxicity in a human and was awarded the East Coast Muscular Dystrophy Association fellowship at Columbia Presbyterian in 1986. During his time at Columbia, he contributed a chapter to a neurology textbook on the topic of adult onset of congenital myelopathies. Following his academic training, Dr. Dickoff entered private practice in Yonkers. During that time, he has worked very closely with St. John's, serving as chief of the neurology service, both from 1995 to 2007, and then again, 2016 to current date, still serving. And he has served on the medical board and assisted in founding the St. John's Riverside Hospital Parkinson's Self-Support Group and served as its medical director from 1995 until the pandemic made us, unfortunately, not be able to host it any longer. He also takes great pride in instructing the medical students and residents at St. John's. Since 2015, Dr. Dickoff has performed a large clinical study on restless limb syndrome, migraine headaches, and bruxism. This has resulted in 15 presentations at professional organizations, including the American Neurological Association, American Academy of Neurology, American Association of Electrodiagnostic Medicine, Movement Disorder Society, American Association of Sleep Medicine, and the New York Academy of Sciences. So that is an impressive resume, and so we are thrilled to welcome to our program Dr. David Dickoff. So welcome aboard.
Thank you, Denise. Thank you very much for having me and to be part of the talks. I really appreciate it.
Of course, we're thrilled that you're here. So let's dive right into it. Tell us first, there's an awful lot of talk about Alzheimer's. Alzheimer's is a form of dementia, but can you really tell our audience, and remember, we're a community audience, what is the difference between Alzheimer's and dementia?
Well, Alzheimer's is probably the most common cause of dementia. It likely explains 80 or 85% of all cognitive decline that's pathological in the elderly. Other types of dementia that you want to ask about include multiple strokes, or what's called vascular dementia.
Okay.
That's seen almost exclusively in people with predisposing risk factors to stroke, such as diabetes, high cholesterol, and hypertension. Vascular dementia is less common now than it was when I first started studying neurology, because of wonderful medications available
to prevent stroke.
to prevent high blood pressure, diabetes, cholesterol, and to treat atrial fibrillation, some of the four main causes of multiple strokes. So because we have the medical prowess to reduce the risk of stroke in most people who have those risk factors, vascular dementia is decreasing in incidence.
Okay.
Unfortunately, Alzheimer's disease is increasing in incidence.
So before we get into why that might be, can you tell me what there are other dementias? Lewy body, that one was in the news greatly when Robin Williams was diagnosed with it. And then the frontotemporal dementia. What constitutes or sort of describes those versus what we're going to talk about in more length in Alzheimer's?
Yes, these two are less common than Alzheimer's disease by many factors. Lewy body dementia is very closely related to Parkinson's disease. It's associated with the accumulation of an abnormal protein in the brain called alpha-synuclein, which is the same protein that accumulates in Parkinson's disease. In fact, in many ways, they're mirror images of each other. For example, Parkinson's disease, which is much more common, begins with tremor, then progressive gait dysfunction, then dementia, and then hallucinations. Lewy body dementia, or Lewy body disease, starts with hallucinations, then dementia, and then gait dysfunction, and then tremor. So they're very closely related, but they seem to have a natural history that occurs almost in reverse.
That's so interesting. We can come back to that because that really is very fascinating. The frontotemporal dementia.
Frontotemporal dementia is a little less known about it. It's got a large genetic component, more than the other dementias, and there are two types of frontotemporal dementia. One that predominantly affects speech. So when someone in their 60s or 70s has a progressive loss of communication skills, that could be frontotemporal dementia. In fact, the speech loss is out of proportion to the memory and cognitive features. The second form of frontotemporal dementia is one that affects behavior, where people begin to have psychotic or aberrant behavior as they have cognitive decline.
So
about 40% of those conditions of frontotemporal dementia is inherited. And curiously enough, the main gene that causes frontotemporal dementia also causes a genetic form of Lou Gehrig's disease.
So those two diseases, as opposed to what you were talking about, Lewy body and Parkinson's, don't seem particularly related in terms of their symptoms, but they're coming from the same inherited gene. Now, you also, that's about 40% have an inherited gene for the frontotemporal dementia.
But a substantial number.
A substantial number. So if you have that gene, you may or may not develop that, but you also may develop Lou Gehrig's disease.
Yes. And I have families that present with this predominant speech dysfunction and cognitive decline who have one or more relatives with Lou Gehrig's disease, and they will tend to test positive for the gene.
Wow. So is the Lewy body dementia also genetic? Is there a genetic component?
No, it's more like Alzheimer's disease in that it's acquired.
Okay.
Lewy body disease is the accumulation of one protein called alpha-synuclein, and Alzheimer's disease is the abnormal collection of two proteins, actually, beta amyloid and phosphorylated tau. And they accumulate gradually, beginning probably in earlier adulthood, because we know that these proteins can accumulate for 10, 15, 20 years before the development of cognitive decline.
So let's go back. And so the acquired subject, that acquired disease is what I really want to focus on. And that's actually very clear the way you've described the differences in these dementias. But Alzheimer's, let's kind of get into Alzheimer's. So talk to me about the symptoms of what people are seeing, and well, actually, before we get into that, how do people acquire Alzheimer's disease? Where is it coming from?
The cause is completely unknown. We do know that the pathology that is the development of collections of abnormal proteins that were described in 1893 by Alzheimer himself, who studied people who had dementing illnesses at a very young age, in their 30s, 40s, and early 50s. Of course, life expectancy was much shorter then, but it's still very unusual. In those days, we didn't have CAT scans or MRI scans. So how did we know what was going on in the brain? Well, we studied patients and took careful notes about what the clinical course of the condition was. And then when they died, we collected the brains, cut them, and looked at them under the microscope, essentially. And in doing so, Alzheimer's described two collections in the neurons of the brain. He described amyloid plaques, and he described neurofibrillary tangles. Now, jump forward 70, 80 or more years, when we had the chemical means of analyzing both the plaques and the tangles. And we found that the amyloid plaques were collections of beta amyloid. It's a normal protein in the body. It probably has a significant function. But what happens in Alzheimer's disease is that for some reason, the protein changes its shape or configuration. And in doing so, the body loses the ability of breaking it down and removing it from the brain. So it collects in three places. The abnormal protein then collects inside neurons, eventually ruining the metabolism and destroying the neurons. It collects in the tissue around the, between the neurons. Some of that may be occurring in the tissue itself. Some of those collections may be the residual of collections in neurons that were killed, where the neuron, the material of the neuron is actually metabolized and removed by the garbage collecting system of the brain. But they still can't remove the plaques and tangles, so they sit there outside in the tissue between the cells. The third place that amyloid is collected, which is very important, is in the surrounding area of the smaller blood vessels in the brain, not the large arteries themselves. For example, hardening of the arteries or atherosclerosis is predisposing to vascular dementia. But in Alzheimer's disease, the collection of amyloid protein in the smaller blood vessels actually causes vascular impairment as well. So in so many ways, Alzheimer's disease is not only a degenerative condition, it's also a vascular condition.
Really? So so it's not a genetic, Alzheimer's itself is not genetic.
No, that's not true. There are a number of different genes that actually can cause or predispose to Alzheimer's disease.
Really?
And when I say it's predominantly acquired, it's because it's by far away the most common, with hundreds of thousands of Americans now having it. And with the aging of America, I saw an estimate that by 2040, there'd be 5 million or more Americans with Alzheimer's disease, because the incidence increases with age. It's seen in about 5% of people in their 60s, 10 to 15% of people in their 70s, up to 40% of people in their 80s, and over 50% of patients in their 90s. So the incidence of Alzheimer's disease is clearly age-related, and that has to do with the accumulation of these proteins. Once the proteins are seeded somehow in the brain, they continue to collect and reproduce because they can't be removed. And so they accumulate over time. And that's why the incidence of Alzheimer's disease increases with time. But there are two different ways in which there are genetic factors that allow Alzheimer's disease to run in families. And it's very important, and we see it very often. The first group are pure genetic predisposing factors to Alzheimer's disease. And we have a couple of that we know the genes. We have presenilin, we have amyloid precursor protein, and there's presenilin 1 and presenilin 2. There are blood tests available for these genes.
Interesting.
And so that if you have somebody where you see a family history, you can test the patient and see if they have a positive genetic test that would allow you to do counseling, which is often very difficult for children and descendants and relatives of the patient themselves. But there's also another important genetic factor that's probably more common, which is ApoE4. There are 3 types of ApoE proteins, 2, 3, and 4. And if you have one gene for ApoE4, it increases your risk of developing Alzheimer's disease by 4 times. Not 4%, but 4-fold. If you have 2 copies of the ApoE4 gene, you have a 10 times higher risk of developing Alzheimer's. And so this is not a death sentence, for example. It doesn't guarantee that you're going to get Alzheimer's.
But your odds increase.
It's clearly a risk factor. And that also could be measured in the children of patients with the condition if they have a positive test.
So, all right. So the counseling on the genetics is very interesting to me, because what do you do if you've been tested and now they're telling you that you have this predisposition and that your odds are unfortunately better of getting it, not 100%, but definitely better. What can you do about that?
Well, it doesn't change the treatment. One thing it does do, it certainly helps you secure the diagnosis.
Okay.
There's no specific diagnostic test for Alzheimer's. Well, there's one that's very helpful, which is called an amyloid scan. You could put a patient in a PET scan and look to see if they're accumulating amyloid in the brain.
And that would look like plaques in the brain?
It lights up. It just it changes the color of the scan. And you can't see the plaques. The plaques are microscopic. Okay. But the scan gives you an estimate of how many plaques there are. And that's important because one of the problems with doing drug research in Alzheimer's disease is, since you're never 100% sure of the diagnosis, you're never 100% sure that the patients you're studying all have the condition you're trying to treat.
So wait, so that's upsetting. That's upsetting, right?
Yes.
So you're sort of working in the dark. If people are exhibiting certain behaviors that are part of having this type of dementia,
which we will discuss,
but if they're having that, and you do a scan or you do the genetics of other family members, and you look at what the odds are, you still can't definitively say this person has Alzheimer's.
No, but the odds tend to bundle up in favor of the diagnosis. So it gives you more.
So it's a process.
More security. Yes. Yes.
So what's that process like in terms of time?
Well, the first thing is to distinguish between what you think is pathological memory loss from normal age-related memory loss. And many patients will come to see me over the years saying they can't remember where their keys are or where they parked their car. And I say, I understand that.
Me too.
Right. And so you do sort of a standardized test that takes about 4 or 5 minutes to do in the office, called a mini mental status test. And there are other tests that you could do as well to test patients' cognition, but the mini mental status is well founded over time, has been used as a measurement tool in Alzheimer's research. And if you practice it, if you do the test in your office a number of times, you really get a sense of what the results mean. So you do a mini mental status, which is a series of 30 questions that tests orientation. Do you know where you are, the date, the location? Can you remember objects short term? Can you manipulate information by doing reversals or calculations? Can you construct 3-dimensional objects on a piece of paper? Are your language skills normal? And you do the same test for everybody. And most people will score 28, 29, or 30. And that's essentially someone with normal cognition. And somebody who scores less than that likely has the beginning, middle, or more advanced process that's causing a congenitive dementia.
But then you don't know that it's you don't know that it's Alzheimer's versus Lewy bodies versus the other forms. Okay.
Exactly. And as part of the historical process, you'll take a family history.
Right.
Did either of your parents have memory decline as they got older? And of course, it has to be followed up with the question, did they get older? Right?
Yes.
Any
Okay.
any first degree relatives, any siblings, and it's amazing that not uncommonly, an older brother, a parent, a maternal aunt will have had a fairly good story for a progressive memory loss beginning in their 70s or 80s, and that increases the patient's risk as well, even if they
Wow.
don't have one of the genetic factors that we discussed. If it's strongly genetic, you will get some counseling with the patient and the family. Do you want to pursue this genetic testing? What are you going to do with the information when you get it? How is it going to affect your life to know this or not know this? Right? And sometimes the genetic tests are not covered by the insurance company, so patient or children sometimes have to cough it up to get this information. So that also has to be discussed. Then to distinguish between somebody with cognitive loss on the basis of Alzheimer's disease from one with a vascular dementia, you do an imaging study. And for sure, the imaging study of choice is an MRI scan, which shows vascular disease, particularly microvascular disease, or what's incorrectly but often called mini strokes, much more sensitively than CT scanning. And you make an assessment of, number one, the volume of the brain. Is the brain shrinking? Are the fluid-filled components of the brain expanding? Is the brain itself changing its shape? Is it shrinking? And then in the brain itself, is there a lot of microvascular activity? Or are there a lot of mini strokes that you see on the MRI scan?
Wow.
And that will help you at least begin to separate a more purely vascular dementia, which again is seen in patients with vascular risk factors: hypertension, diabetes, high cholesterol, family history of stroke, smoking, and
Okay.
atrial fibrillation. Okay.
Wait,
And again,
let me stop and ask you a question. So we're in an epidemic in this country with cardiovascular disease, right? Everybody's got high blood pressure, where everybody's trying to avoid taking statins, but they're taking statins. Do any of those things, if you know that you have, like I have a genetic component to my cardiovascular issues, uh, definitely my father had it. Is the treatment that are available, can that prevent this progression of the vascular derailment in the brain? Will that prevent that kind of thing where you're not going to have the mini strokes and all of that?
well, there are two answers to your question. I do want to quickly field them both.
Yeah.
The first is some of these factors are genetic, and there's not that much you can do about genetic factors, right? For example, what is the most important non-modifiable risk factor for Alzheimer's disease? The answer is age. Can't do anything about it, right?
Yep.
But a lot of the issues with blood pressure, diabetes, and cholesterol also have environmental factors that are modifiable, right? Diet, exercise, cognitive exercise, okay? These are things that are kind of underappreciated in America. We're a very wealthy society. We have lots of food on our table, most people, thank God. And we tend to eat things that are cholesterol rich. We have obesity is a major problem in this country. That is a predisposing factor to both diabetes and high blood pressure, and I think cholesterol as well. So there are non-modifiable genetic factors, but there are clearly modifiable environmental factors that could be started at a much earlier age. In other words, if everybody in their 20s and 30s had a modicum of aerobic exercise, ate healthier, keep their cholesterol down, avoided obesity, then without the use of intervening medications later on, you can reduce or delay the development of hypertension, diabetes, and high cholesterol. Of course, smoking is not easily modifiable, but definitely modifiable risk factor for these conditions. So clean living is going to reduce the risk of Alzheimer's disease as we age, because it's going to reduce these risk factors.
Okay.
And it clearly reduced the risk of vascular dementia, but also reduced the risk of Alzheimer's dementia as well.
Very interesting. So let's turn our attention to maybe you don't know that this is an issue in your family. Maybe you didn't know your grandparents. Maybe your father had a heart attack or something happened and they didn't live to 90. So you never really knew that there might have been a developmental or a genetic issue. So the family history, you may know nothing about. So I'm now watching my mom, let's say. And are there things that I should be recognizing, looking for, thinking about? Am I looking for certain behaviors? So I now, like you, have senior moments. I'm like, oh God, I don't know, what was I thinking about? What am I talking about? Is that a thing? Because that happens frequently with older people. Is that normal versus what's going to tip you off to know that there's something really not right?
That's a great question and really segues us into the clinical manifestations of Alzheimer's disease. Those early in the stage, early Alzheimer's, middle Alzheimer's, and later Alzheimer's disease. And there's a lot that goes on in terms of the delay in the diagnosis of Alzheimer's disease. This didn't used to be a major issue when there were no good treatments available. Now there are some, and there probably will be more coming in the future. And those treatments are clearly more effective in the early stages of the disease. Okay?
So do they
prevent
the progression, or is that what happens? Is that how they work?
Right. Some of the newer treatments may slow the progression of Alzheimer's disease.
Okay.
And starting the disease in the earliest stages, therefore, helps you preserve people's function, right? I mean, when's the most important time to treat cognitive decline? Somebody who's working, supporting a family, sending kids to college, planning for their retirement, who their ability to work from, I used to say 60 to 65, but now I will say 65 to 70.
I know.
Which is true. If you look at demographics in the country, it's really true.
It is true.
I mean,
we're right there.
Even the Social Security Department has basically said, you can't retire yet. We're not going to pay you for 3 more years.
That's right.
So that basically reflects the demographics of our society. But somebody who is beginning to have some mild cognitive decline at 65 may not be able to accomplish the things they had anticipated between then and 70, right? And then take it another step further. They plan to travel at 70 to 75, right? So starting to treat this condition earlier
allows that
and does allow people to continue to be productive and generative in our society and allow them to travel and accomplish some leisure activities that would not be possible if the disease were untreated. So there's less therapeutic nihilism than there used to be. People who understand these things about productivity and leisure time and the aging of America, it really is an impetus to have treatments that work and to start them early in the condition, which leads us to your question. How is the diagnosis? When do people come to medical attention? Okay.
Yeah.
And it's remarkable that some people will come quite early in the condition, and they're basically come to ask the question that we addressed before: is this memory loss normal for my age, or am I looking future problems? When the memory loss gets a little more advanced, it is usually the family members now that will introduce the potential patient to the doctor, and that could often be quite delayed. Okay.
So what does that really look like in the house? I'm watching someone try and do things. What would stand out to me as an observer?
Well, remember, most individuals, when they begin to have cognitive decline, are usually living independently with or without a spouse. Most of these people are not living with siblings or in a family setting. Okay, So the usual presentation is retrospective. Okay? I usually start the discussion with, when did this start? And I ask the patient, when do you think your memory problem started? And half the time they'll say, I don't have any memory problems. And then the child will look at them and say, Mom or Dad. Right? And then I'll say, well, when did it start? And it's remarkable, but it's often a year or two or three that they haven't
sought they're sitting in front of you.
That they haven't sought before they're sitting in front of me.
Right.
And that maybe there's some delay in referral from the primary care doctor, but usually it's the delay in recognition of the symptoms.
Right. Okay? So what are the symptoms?
Right. Well, let's go back in time. In retrospect, what did Mom do 2 years ago that now is giving you thoughts? Well, I used to call her in the morning and tell her that we'd be coming over for dinner on Friday. And then I'd call back in the evening, or she'd call me and she'd say, I haven't spoken to you in a while. Am I going to see you soon?
Okay.
So it became clear in retrospect that the patient forgot the morning conversation and the upshoot and result of the conversation. Okay? Yeah. And then the family will say, oh, but we reminded Mom, we called her again. We've gotten in the habit of reminding her. Last 6 or 12 months, I've been setting up her medications. We thought this was normal aging. Doesn't this happen to everybody's parents? And as usual, it's often as not, the actual intervention of a physician is requested when there are either behavioral issues like wandering, getting lost in a car. I can't begin to tell you how many Alzheimer's patients present with, she called me from Poughkeepsie.
And you're sitting in Yonkers, yeah.
Right. And where were you heading? I was going to the grocery store. I've been driving there for years. Right. And so this is the kind of more obvious or egregious or right, the kind when it slaps you in your face, you ask a doctor why. It's not, this isn't normal aging anymore. Okay. And that may still be in the relatively early stages of the disease. Okay. But it's important at that point to intervene, not so much to keep a person working for 5 years, right? But to keep them safe at that point. Okay, when do you have to take away the car keys? One of the hardest things that we ever have to do. Fortunately, I don't do it. If people want to donate their cars to me, I have 4 kids, it's okay. But that's not generally the way it works. You have to have long discussions with the aging person to kind of convince them, your college-age kid is graduating, and maybe they need your car more than you do, and don't worry, you're not going to be locked in the house to be able, it's not easy, okay? But how vital is that, right, to protect people's lives?
Yes. So my takeaway from this part of our discussion is that if you're looking at someone who's aging in your life and you're beginning to notice things like that phone conversation, or they call from, I don't know how I got here, those you should not be waiting. Because you started to talk about treatments. You did say that there now are pharmaceutical answers that can delay the progression and keep the person safe and allow them to have more of a life for a longer period of time. But what else besides...
You summarized that beautifully, by the way.
Thank you.
Yeah.
But what else is there other than the pharmaceutical answers? And then what happens when the disease actually does start to progress despite that medication? What's the next step? What is that progression look like?
Well, the early stages of the disease, as should be clear to the audience now, is short-term memory issues. Right. The patient will be able to remember their wedding anniversary, what the band played, what they wore, their kids' birthdays. The longer-term memories are well ingrained, and they're not lost until the very late stages of the disease.
Okay.
But the ability to process and to recall immediate events is the main hallmark of early Alzheimer's disease. Forgetting the telephone conversation, walking into a store and getting, 5 of the 10 items that you needed to buy. The things that we find ourselves repeating to ourselves in order to remember.
Right.
Short-term memory, that's the hallmark. And so how does that affect people's ability to live by themselves? Well, the answer is you forget if you've eaten.
Or that you've put something on the stove to cook.
Very scary, yes. It's one of the main reasons why people need to have supervision or have to be removed from their homes. How about this one? I can't remember if I took my medicines. Now I have the choice of not taking them today or taking them twice.
I'm just going to tell you this funny stories. I leave my house every day, and then I get halfway down the block and think, did I shut the garage door? But I have come to know that that is not a problem with my brain, but just a problem with my attention span. So I'm
there are
happy
other
to
possible
say
causes we can discuss later.
Okay, we will discuss that later. Wow. All right. So
we can edit that out too, Denise.
Okay. Well, I don't really mind, and that's all fine. Okay, so
it's good to be a little obsessive. No, it's good to be a little obsessive. A little obsessive gets you through the day, stops a doctor from making mistakes, and believe it or not, a little obsessive behavior actually helps Alzheimer's patients stay at home safely. Okay?
Because they go back and check and go back and check and go
not
back
even
and
that, not even the checking, but the habits. I get up in the morning and I take my pills, I have my orange juice, I get the newspaper, I walk the dog.
The habitual life that is being led.
Yes, it makes things go longer than if there are changes.
Okay.
The structure,
so change is not great for these patients.
Well, they can't deal with change because they can't remember what the change is because it's a new piece of information. The habits are the old memories that we were discussing that are preserved. The changes are new memories that are forgotten.
Right. So you talked about there's some really great treatments now, some medication treatments. Are there things in research that are looking good, that are hopeful? I know you've always got your finger on the pulse of those things.
Yes, there are. There are.
Interesting.
The evolution of treatments for Alzheimer's disease, pharmaceutical treatments and now biological treatments, have been ongoing for since the early 1990s. The earliest theory about the memory loss in Alzheimer's disease, and this, in retrospect, pretty simplistic, was a deficiency of a chemical called acetylcholine. Acetylcholine has long been known to be the memory chemical because it's the main neurotransmitter in the part of the brain called the hippocampus, which is where our short-term memories are processed. And when you have high-grade MRI scans and before that CAT scans, you could often see an early hippocampal atrophy or shrinkage in that part of the brain, which processes short-term memory. And so we knew that the neurotransmitter, the chemical that subserved short-term memory in this part of the brain, was acetylcholine. So the earliest treatments in the 1990s were medications that increased acetylcholine levels in the brain.
Wow.
And we still use them. 30 years later, the principal drugs that we use are still medications that elevate acetylcholine levels. And they work moderately. They work in about 2/3 of patients. We don't know why the other third don't respond, but they don't. And initially, some of that might have been non-Alzheimer's patients that were mixed into the study. Okay?
Right.
Now, so 2/3 respond, and the response peaks at 4 to 6 months and then begins to slowly decrease the benefit, but persists for about 18 months. So these medications can increase short-term memory for 18 months, which is exactly why you want to start them early in the course of the disease. Keep people working, keep people active. I had a patient who came in springtime, early summer, who had some pretty striking short-term memory loss. And she was placed on this medication and came back for a checkup 3-4 months later, and she scored normally on her mini mental status examination.
Wow.
It was a very
Wow.
robust response. I don't promise it to any of the listening audience, but it does prove that these medications do work. The daughter was remarkably surprised, but probably not as surprised as me. Okay? But it's not going to work for that much longer, another year perhaps, or another 18 months. Another drug was introduced, and there were three medications that all work by the same mechanism of action that were introduced a few years apart from each other between 1990 and 2000. Okay? Then we had very little added for almost 20 years to our armamentarium for Alzheimer's disease. We spent a lot of time working on preventative strategies, which I've already discussed and are really important, everybody out there. Okay? Walking on a daily basis or 3 times a week will reduce your risk of Alzheimer's disease. Hello.
Well, that's fascinating. I've
so
never
important.
heard that. I've never heard that.
Yes. And paying attention to nutrition, diet, blood pressure, taking care of the things we need to take care of, right? If you reduce your risk of heart disease, you reduce your risk of stroke, you also reduce your risk of Alzheimer's disease.
Interesting.
But recently, the emphasis has been changed from trying to modify the chemicals that we thought we were involved to trying to address the abnormal accumulation of the proteins that I mentioned earlier in the talk. The accumulation of the beta amyloid, where the protein misfolds and then cannot be removed.
Entangled, right.
And the tangles. So we don't have tangle drugs yet, but they're the next step. But what has happened in the last few years is the pharmaceutical industry has produced antibodies, which are now not a chemical so much as a biologic, which means it's similar to things that exist in our bodies and other animal species. And the antibodies are large proteins that are produced by our immune system. Right. And they're produced throughout our life to protect us from viruses and bacteria and toxins. And when you get a virus, why don't you get it again? How does a vaccine work? And the answer is that protein stimulates the immune system. The immune system goes through a large cascade and ends up producing these proteins called antibodies, which stay in the body, float around, and if the virus is reintroduced, the antibodies are already ready to attack it and remove it from the circulation. Okay?
So it's immunotherapy, and that's also something that's coming along in cancer care as well.
Yeah, and it's there already. It's coming, and it's been there. And so,
very interesting.
So the issue is now you can get bacteria and animals in a laboratory to produce antibodies, right? If I inject a protein into a rabbit, that rabbit's immune system is not dissimilar from humans, and they will produce antibodies to that protein. You can harvest those antibodies now and experiment with them, okay? So you can produce antibodies to almost any kind of protein or antigen. Okay?
Wow.
So what the scientists did was they took amyloid or components of amyloid and produced a series of antibodies that are able to bind to, scavenge, and theoretically remove amyloid the same way it might remove a viral particle and help prevent an infection. So
that's amazing. And that has given me, I feel like we're coming to the end. We have one more question for you, but that just is such a hopeful, idea. And how long do you think it's going to be before we get these things? Are they in trial?
No, they're available.
They're available.
Yep. The first one that came out was pushed through a little quickly by the pharmaceutical company, and they got in trouble. It turned out to be not as effective as everybody promised, and a big launch and a lot of hubbub actually caused quite a scandal in the FDA because...
Wow, too fast.
Well, because the board of neurologists that were asked to advise on it recommended that the drug not be approved but be studied more. And the non-neurologists actually approved the drug in spite of the recommendation of the subcommittee.
Okay, so...
But now, hold on. But now there are two that are approved, that are efficacious, and they are better than the first one.
Okay.
And they're available.
And so you see results from this.
Yes, I actually have patients who are receiving it already.
And what are those results looking like?
Ask me in 6 months. We'll do the talk with a little different bend.
We'll do it a different way, and I'll definitely do the talk with you in 6 months. I have one more question that I think is very interesting because it does speak to our environment and it does speak to the things that we are eating and the nature of our food supply. But you know, Alzheimer's, as you started the talk with, is definitely rising, right? We know that the numbers of people getting it are going up. Why?
And at a remarkable cost to society, everybody. It is
Yes.
so worthwhile investing in these preventative strategies because this disease will bankrupt us by 2050.
All right, let's not go there, but why is it that the numbers are rising that way? Is it the environment? Is it the food? Is it our lifestyle? What is it?
Okay, a very controversial question, and I am going to probably now say something which is very controversial.
Okay.
I started the talk with a normal rendition that the cause of Alzheimer's disease is not known. And if you go online and look at Wikipedia, that's what you will read, okay? But since we do know that the disease is caused, as far as we understand, by the accumulation of an abnormal protein, which is a modification of a normal protein in the body, and we do know that this protein actually can replicate itself and take normal amyloid and make it unmetabolizable. In other words, amyloid is floating around in the brain. It's doing whatever it's doing. But once it is exposed to the abnormal protein, it changes its shape and becomes abnormal, creating a cascade accumulating this protein. It turns the normal amyloid into abnormal amyloid, okay? So we're addressing it in a backwards way, right? We're developing antibodies to remove the abnormal amyloid. The real question that you guys are all asking yourself at this point is, how does the abnormal amyloid get into the brain in the first place? Well, one possibility is that there's a genetic predisposition to the misfolding of this protein that then causes this cascade. Okay? The second possibility is that the abnormal amyloid is actually acquired from the environment, possibly in the foods that we eat, and possibly even in the pollutants in the air. There was a recent article that actually just came out a few months ago that suggested that exposure to air pollutants increased the risk of Alzheimer's disease.
So let me just ask this, because I just saw this in the news, but they're talking about Alzheimer's being type 3 diabetes. So can it be sugar driven?
Clearly, diabetes is a clear risk factor for it, and the presence of high blood sugar in some way does promote this condition, but it's probably not going to turn out to be
a causal. Okay.
No.
Okay. Very interesting. Doctor, I hate to end it here, but I am going to have you come back because I think this is such a great conversation, and we can do some more. For our audience, we are going to be evolving these webinars into more of a live program coming in the new year, and live meaning in person live, so that we actually are sitting in the same space and the same place. And so I thank you, Dr. Dickoff, for this wonderful, very educational, very informative discussion on dementia and Alzheimer's, and we really appreciate your time. So thank you so much for being with us.
Thank you for having me, and I look forward to coming back for variations on this or many of the other topics in neurology that are very important to our society. And I also look forward to meeting our audience and participating with them next time.
Absolutely. All right. Thank you so much. Have a great day, everyone.